Good evening, everyone. We welcome you all to OrthoTV online. This is the weekend PG clinics program conceptualized by Dr. Tushar Agarwal and Dr. Harshad Argekar in continuation and in demand after the successful IOA Con PG teaching program. To introduce today's topic and the speaker, I hand over to our convener, Dr. Tushar Agarwal.
Yeah, thanks a lot, Neeraj. Thanks a lot, OrthoTV, for allowing us to do this program, and we welcome all the postgraduates who have taken the time out to join us. We would also appreciate if you spread the word right now and every Saturday to your colleagues to join us. More and more PGs join, it always boosts the morale of the teachers. As I must say that it's quite tough on us also to come on Saturday night and do this course. So today evening, we'll just continue with the elbow session, which we had taken on last time. As last time, you know, we took supracondylar cubitus varus, non-union lateral condyle. We had Dr. Taral Nagda's lecture on radiology about the pediatric elbow, and we had a talk on elbow examination. So now today, Dr. Atul Bhaskar will take two talks back to back on an unreduced Monteneggia. That's a missed Monteneggia. That can be one of your exam cases, and a general overview of what is the definition of a stiff elbow. I'm sure your examiners are definitely going to seek out these kind of patients and keep them for you in the exam. And another thing is, when these patients come in the ward, they rarely get operated right away. There's really no rush to treat them, so they keep circulating in the exam. So I'm sure a stiff elbow, either in a pediatric or adult age group, is definitely. So today's talks are basically geared up to teach you more about the stiff elbow. So over to you, Atul.
So I'll start off with the first talk. I'll just share my screen. Can I share my screen?
Please.
Let's see. Is the screen seen? I'll just make it large and then. Yeah, is it visible now?
Yes.
Okay. So my first talk is on the approach to a stiff elbow. Actually, a presentation of a case. So the etiology one has to decipher from the history, but stiff elbow is a sign and a symptom. So when a child comes to you, what process should we go through before we come to a diagnosis? Now, if you look at as we go to the basic, always the history will tell us the details, and the devil is in the detail only. Whether the deformity started at birth, so they cover a lot of other conditions like AMC, dysplasia. We rarely come in the exam. What comes in the exam is usually a post-infective sequelae, either a septic arthritic of the elbow or Cox elbow, which presents with elbow stiffness. Post-traumatic injuries form the second bulk of cases that present with the stiff elbow. So it could be any intra-articular fractures or even extra-articular fractures leading to myositis, which can come. Inflammatory joint diseases like JRA, hemophilic joints are rare to come in the exam, but they form a part of the differential diagnosis, especially if you have multiple joint involvement. Then JRA and hemophilic joint usually can present with multiple joint problems. Hemiplegia only in the late stages, when they present with disuse, they can come with the elbow stiffness, but the history is very classical. One should also inquire the history of treatment for the child. What is the mode of presentation? What treatment the child had taken, whether he had taken any treatment on time, whether there was any delay in the treatment, either of an infection or a fracture. If there was an injury, whether there was cast immobilization, potential wound infection, pin-tuck infections, when there was wires inserted, a role of physiotherapy, which I'll touch upon later as well, and whether there was any concomitant head injury in the presence of a stiff elbow. So a lot of the clue can come from the history of the presentation and what treatment the child had taken. Especially in a post-op case, one must have the details about the duration of cast immobilization, because that can influence the elbow stiffness, especially in the early part of the presentation. There can be several sites of block in the range of movement. Extra-articular blocks can be mainly in the skin and the soft tissues. So these are like soft tissue contractures and arthrogryposis, wound infections, compartment syndromes, sequelae. Intraarticular adhesions can be from the capsule, joint synovitis, if there is bone growth in the fossa, both in the olecranon fossa as well as the cubital fossa, because of either implants or because of fracture healing, there could be intraarticular blocks. Often you see combined problems, especially in sepsis and in post-traumatic stiffness. You can have a combined extraarticular as well as intraarticular capsular block, which can sometimes be difficult to separate. So typically you look at the Aplay's concept of look, feel and move. So when you look at the joint from all sides, so look at from the front, from the back, from the sides, and see whether that's and compare to the dominant hand, whether there's any wasting. You compare with the opposite normal side in terms of the contour, the soft tissue contour, the bony contours. Look for any scars and sinuses, like in this child who underwent a radial neck fracture treatment. One must look at the supracondylar ridges, whether there's any thickness, the fullness of the fossa, the overlying skin texture, if there's any evidence of any inflammation or past infection. And of course, the atrophy just tells you the disuse or the duration of disuse. So a lot of the information can come from purely inspection, whether this is a post-operative case, where the scars are located, or whether there was a wire or there was a internal fixation done. And more or less, you get an idea whether this is post-traumatic stiffness. Of course, you palpate, look at the tender points. Again, you start a systematic approach from lateral to medial and see where if there are any tender points, which is very rare from the exam point of view, because you won't get a case which is acutely tender. You must know the bony landmarks and the relationship. So, of course, compare with the opposite side, mark the bony landmarks, the olecranon fossa, the middle epicondyle, the lateral epicondyle, the proximal radius, and the proximal ulna. So you get an idea where the bony relationship is. And measure the girth for any wasting and the length of the forearm and the arm, especially in cases of congenital or dysplasia where there can be some limb length discrepancy as well. You must measure the active and the passive range of motion, ligament instability, which I'll touch upon, and in the end, a thorough neuro examination to make sure that there is no neurological cause or post-traumatic cause with some neurodeficit, which you can miss. Don't forget to examine the hand and the fingers, the sensation, the motor power. If you look at the stability of the elbow, usually it is the extension arc that is affected. Limitation of pronation and supination is very rarely observed unless there is involvement of the radiocapsular joint. So any radial neck fractures, proximal radial injuries will only give you restriction of supination and pronation. Otherwise, it is usually restriction or extension. From the stability point of view, this is from Morris classification. If the elbow is lax, less than 5 degrees, then there's a mild instability. If the laxity is more than 5 degrees, then it's moderately unstable. And severely unstable elbows, you've got more than 10 degrees of varus or valgus laxity. Of course, to have laxity in an elbow, you must make sure that the elbow is fully has got good range of movement. So very rarely you get instability with flexion, unless you've got a bony loss. So if there's bone loss or bone resection has been done for a particular case, then only you can get instability with stiffness. Otherwise, getting instability and stiffness is actually contradictory. But the only condition you get is if it's a post-traumatic case and there's been a bone excision. So one must test, especially if there's radial head excision or there is radial head necrosis, you may get some varus valgus instability. So when you come to a diagnosis of a stiff elbow, you must give a diagnosis which covers most of the points in this format. So this is a case of right or left elbow stiffness, secondary to whether it's post-traumatic, post-infective. The chief complaints of, so here you mentioned limitation of function, whether they can do the day-to-day activities, having active range of movement, not passive, you must mention active range of movement with functional limitation. In the right or left hand, in the left or dominant hand. So I think in the diagnosis, one must cover all these part and give a straight answer in one sentence. So just a couple of examples. This is a child who had a stiff elbow following a post-traumatic injury, and many of the cases occur as per literature in case of neglected trauma. And most of them either you get a case of neglected elbow dislocations leading to stiffness, both intraarticular as well as extraarticular. You can also get stiffness in supracondylar fractures post-operatively, or they're malreduced. And sometimes certain lesions which are difficult to determine, especially middle epicondyle injuries. So if this child has got a middle epicondyle fracture which is trapped inside the joint. So when you get an elbow X-ray, only look at the intra-articular pathology, look at the AP view, look at the physis of the elbow, the radial head, the olecranon, and on the AP view, the middle epicondyle, because that can sometimes displace. Also, you can comment on the ossification in the front of the elbow. So this is capsule ossification. So there is an intra-articular pathology. There's also the extra-articular this calcification, which can cause stiffness of the joint. X-rays are the key to diagnose. X-rays can tell you about fracture union, fracture reduction, alignment, loose bodies, bone stock. So when you look at the X-ray of the elbow, one must comment on all these features. CT scan in the coronal and the sagittal planes are most helpful in assessing the etiology of stiffness. MRI can sometimes overestimate. So CT reformatting is the best imaging modality for a stiff elbow. Sometimes you may assess the intra-articular fractures through lateral reconstruction of the CT scan image. So when you look at the reformatted image, that's the best way to look at intra-articular fractures. The AP view assesses the anatomy. So in the coronal AP view helps you assess the anatomy, and the lateral reconstruction view or the lateral reformatting looks at intra-articular fracture. So CT is very, very useful to assess any kind of intra-articular pathologies, including loose bodies. So a couple of examples of a child who underwent, this was a child who had a TY fracture who underwent surgery, and here he presented with about 30 degrees of loss of movement and 10 degree loss of flexion. Now, typically in the first few weeks, up to 3 months, they can have this kind of presentation. So any range, any loss of elbow range of motion after 6 months of injury is classified as a stiffness. And that 6 months duration is because that is a reasonable time required to recover elbow range. And that's why when you call an elbow stiff, it can only be called 6 months after an elbow injury. You cannot call a stiff elbow when the cast comes out after 3 months, because it takes sufficient time for the elbow to regain motion. This is an example of the girl I showed you earlier. She had radial end head fracture, which was treated with the KR fixation. This was open reduction and fixation. She had some pin track sepsis, and there was stiffness. She underwent aggressive physiotherapy. The elbow was stiff, and she sustained a fracture of the lower end of the humerus in the therapy, during the therapy. So again, had to be immobilized, and you can see the callus formation led to further stiffness. So this was the range when she presented, almost 75 degrees of FFD up to 90. But this is a combination not only of intra-articular pathology because of the fracture in the pinning, but also sepsis, extra-articular injury, fracture causing stiffness because of immobilization. So these are what is called composite causes of stiffness. So one has to go in the history very clearly. And if this elbow doesn't regain movement, and this girl almost presented 1 year after the injury, which was a classical stiff elbow. So that's when the first 3 months of following any elbow injuries or any elbow fractures, one active range of movement. Don't do any passive movements, and it's been shown that aqua therapy or swimming is extremely beneficial. Any kind of periodic elbow stiffness. And this is from Dr. Mora's article that somehow in water they seem to get a better range if you started very early. How do you treat these? So this was an example of the same girl. You can see under anesthesia, we've done a collateral approach. So typically you would approach, don't take the anterior approach because you cannot release the ligaments. So you start from the medial side and then go on the lateral side. So it's a sequential release of the medial structures. Typically is the medial oblique ligament, which is very, very tight on the medial side. And you can open the joint from this side, transport the ulnar nerve, release any posterior block on the medial side. And from the lateral side, you release the anterior block. So you've done a combined approach for this girl. So you don't try and lengthen the biceps because you will just cause more weakness. Most of the pathology can be approached from the medial and the lateral side, and you can look at the nerve. And this child had a good range on table. You can see the active video, and we could get a decent range on table, and then she was casted in it. This is another example of a late presenting lateral condyle, again, very common cause of stiffness. Besides having elbow deformity, they can have this kind of intra-articular block to flexion. So there you can see the olecranon has gone inside the fossa, and this was causing a block. So this child presented with the pain also because of this non-union. And we did a corrective osteotomy, and this was the range. So he didn't have much range before, and this was his range. So he's now 6 months post-op, and now you can see that this oligurine has gone inside the fossa. So we have not promised him the full range, but he just had a jogger movement, has got some functional range at the end of 6 months, and he's still undergoing physiotherapy, or only active physiotherapy. So we did an extra-articular osteotomy without touching the intra-articular part. So in these long-standing cases, you cannot open the joint and try and reconstruct the joint because there is so much of dysplasia because of the previous. So I think that is my talk on stiff elbow, and I'll hand over the mic to Tushar for any questions or if there are any parts to discuss. Tushar, muted.
Sorry, what I was saying is it always possible to identify whether it's an intra or extra-articular cause of elbow stiffness, or whether it's a combined cause, or in your own experience, you find it difficult to say so? Hello, Atul?
Tushar, tell me. Sorry, I didn't get the question.
I'm saying that intra-articular cause, extra-articular cause, and combined cause. So
Correct.
you find that it's very apparent in all cases, or in some cases it's very difficult in spite of all investigations to really understand what is causing the stiffness?
I think if it is some cases it's very apparent. So if somebody's got a soft tissue injury, you should have massage, you can more or less say that it is because of myositis. But it is not easy to discern in the exam. And I think one has to be very careful in the exam to say this is with confidence. Unless the child has got an extra-articular injury, a distal humerus fracture, put in a cast, and then come with stiffness. So depending where the injury has been. So I don't think one can discern really clinically whether it is extra-articular or intra-articular. I think one has to go with imaging to be more confident. So in the exam, I would not say whether it's an extra-articular block unless you're sure.
Which means that the student should not blurt out that it is a combined pathology. Otherwise, it will be very apparent that they have seen the case before.
Correct.
So they should say that it's not very apparent to me, and I would like to see the further investigations.
Correct. I think
and
that is very
possible,
important.
CT and MRI, and then another thing, if we could touch upon the warm elbow. So if the elbow is warm, would you advise something like alkaline phosphatase? Is it useful in case of myositis ossificans?
So if they come early, so like I said, most of the cases in the exam will come late. So if they come around 3 to 6 months, the elbow usually quiescent. It's the initial warmth and swelling and the dystrophic changes are typically seen in the first 6 weeks to 3 months. And very rarely you get a case in the exam, but certainly it can come as a question that what investigation you would like to do if you have a stiff elbow. Now, unless for example, like the case I showed you, the girl had a fracture, underwent physiotherapy and massage, and then broke the elbow. There was a fracture of the distal humerus. But if you do that kind of massage, and you say, I'll do an alkaline phosphatase, it makes no sense because the child had a fracture. So unless there was stiffness post-massage, they've gone to a bone setter. From the history, you know that this has been not treated by an orthopedic surgeon. There's been some vigorous therapy either by a non-orthopedic person. Then you order the alkaline phosphatase. Warmth elbow can be many things. Somebody who's had multiple attempts of physiotherapy and for a few sessions can also be warm. But if it's diffusely warm, synovitis is one thing, hemophilic, localized warmth, again, myositis is only in the front. It only warmth at the back. So if it's inflamed synovial, then one thing one can think of JRA also.
So, but if the examiner insists on asking whether there is any clinical test for identifying myositis, so is alkaline phosphatase a valid test?
Alkaline phosphatase is a valid test. We've always been taught in exams that do not touch the mass until it is the values come down. Now, one remember what is the value of alkaline phosphatase in a child. So don't look at the adult value. In a child, the alkaline phosphatase can vary from 400 to 800 up to 760.
Yes.
200 and 300. So we must look at the reference range. And that's why it can be sometimes misleading if the reference is not given. In a growing child, is always higher than the adult. So if you have the reference, alkaline phosphatase in thousands, you know better not to touch this child, and you'll have other signs as well. And one can see on the X-rays, because initially there'll be speckle calcification, not mass. So one can do an X-ray and also see that the alkaline phosphate is raised. The calcific mass is not is still diffuse. It's not formed a homogeneous mass. And then it's an evolving myositis, and one can definitely wait and counsel the parents that let's wait till the whole thing resolves, and then we can think of excision or something else.
I think one more question was asked to you that day in the in the IOCON course was this: what is the actual range of movement at which you call it a stiff elbow? Means it should be 20-30 degrees.
Yeah,
or
so what has been shown, any range of motion more than 30 degrees is a stiff elbow.
Less than 30 degrees.
Yeah, less than 30 degrees. So
arc of movement.
Arc of movement, loss of 30 degrees. And again, you compare to the opposite side. Many children have got hyperextension of the elbow. So if somebody's got minus 10 degrees hyperextension and range up to 130, so they may lose 10 degrees, may not matter to them. So always compare with the opposite side and a child. But anything around 30 degrees is called a stiff elbow. So if you lose terminal extension, say of 20 degrees, and it's usually loss of extension. So if you lose 20 degrees of extension, that will be classified as a stiff elbow.
So losing 30 degrees of range of movement.
Correct.
Is stiff elbow in any direction.
Correct. Any direction.
So if this was 140, 150, and if you're at this, then it becomes
110.
Stiff elbow.
So you got your stiffness in flexion.
And if this is coming straight and this is at this level, so then it is stiff elbow.
Right. So in any direction, any arc of loss of 30 degrees, because that will be classified as stiff elbow.
So guys, I hope you're listening to that, because I think those are very important points which Dr. Atul Bhaskar has told you. So we have to look at the symptoms of the patient, the complications, etiology, treatment. And like he said, you have to look, feel and move the elbow. You know the definition of a stiff elbow now and an overview of the treatment. You can manipulate the elbow under anesthesia. If you're not getting adequate range, you can open by the collateral approach. You can go medially, you can go laterally. The medial approach helps you do medial and posterior release. The lateral approach helps you do lateral and anterior release. Right, Atul? And now we'll go to his second talk. So Atul, now you can take your second talk.
Okay, I'll just share my screen.
Yeah.
One second, I'll just go to the share. So the second talk is on the missed Monteneggia fracture in children. And again, it's a very, very common case to come in the exam. In fact, I was taking an exam 2 days ago at one of the centers in Bombay. And I showed an elbow X-ray to the fellow who was giving the exam. Actually, he missed the Monteneggia fracture. And this was at the fellowship exam. So it's not uncommon to miss, because what the eye can, the mind doesn't know, the eye cannot see. And this was a girl which presented to an outpatient clinic. And she had this presentation where there was some loss of terminal flexion. On extension, the mother complained of a bump in front of the elbow. And this child presented to the orthopedic surgeon who had seen the child in casualty. And this was the X-ray at presentation. So you can see there was a fracture of the ulna with a radial dislocation. So this is a classical Monteneggia fracture. Now, this fracture was missed in the exam, in the casualty, and this was the report at discharge. Green fracture of the ulna, followed home. So this is not an uncommon scenario, and this is from a medical college. So it's not an uncommon scenario, either it's in a college or practice. Missing a Monteneggia fracture is extremely common. This is another child who presented with and you can see some scar as well here. So this child had full flexion, some distribution of pronation, and he had this bump on the lateral side. And this was his presentation. He actually presented with a missed Monteneggia fracture, had undergone some treatment. So at the outside, he was missed completely. He had a green stick fracture of the ulna proximally, and you can see the ulna bow with this radial sublux laterally. This was his presentation when he came to us with this bump, and it was painful to press because the head had overgrown. This was the the treatment which was done initially, somebody did an ulnar osteotomy and tried to realign the head back into position without opening the radiocapsular joint, and they put a wire here to stabilize the joint. Then again that failed. Somebody attempted a plating here on the middle side, which is quite unusual to get a dorsomedial plate. And again the head was dislocated. And finally, when they came to us, we did an open reduction, ulnar osteotomy. I put a graft here also. I did ulnar ligament reconstruction for this child. So it is not uncommon to see these cases in practice. And this was his final X-ray where the osteotomy is healed. The radial head is in position. He got a range from 30 to about 110 now. I'm hoping he can improve on that. But he was 18 months post-injury before he went back in. And you can see there's already some radial head changes because this was badly deformed. We've got the ulnar length restored, and also we've done a flexion osteotomy with the grafting. Now, typically when you get an X-ray like this in the exam, the examiner may show you this kind of X-ray and you will comment that this is an ulnar fracture. But never look at that. Always when you look at the X-ray, you must see the joint below and the joint above. Never comment on an incomplete X-ray because this is a sure shot failure in the exam if you don't ask for the joint above and below. This child had a green stick fracture of the ulnar, and you can see that this was the X-ray proximally, and there was radial subluxation. So don't look at the ulnar fracture. I always tell my residents an ulnar fracture is a Monteneggia fracture unless proven otherwise. So look for the radial head, the radiocapital axis, the ulnar shaft axis. Make sure the ulnar shaft axis is parallel to the ulnar border, and the radiocapital axis, the center of the radial head hits the capitulum in any plane. One must know these axes by heart, but only if you insist on both the X-rays. If you don't look at the X-ray at all of the elbow, then you can miss it completely. So this child also completely missed. This was his diagnosis. You can see again written by an orthopedic surgeon, 2016, fracture ulnar double plus, which I don't know what it means, but obviously I missed this completely. But this is not unusual in practice. So again, I always emphasize, look at the proximal and the radial distal joint. Always ask for two joints, one above and one below, before you actually come out on any X-ray. Okay. Again, you saw the child again in the follow-up. Also commented that the fractures he completely healed, but never looked at the radial head. So this capitular radial axis is very important to draw in every forearm fracture. If you make a habit of drawing it in every forearm fracture, you will never miss a Monteneggia injury. And if you draw this line along the shaft of the radius, it touches the radial head and touches the capitulum. In any plane, flexion, extension, it should always touch the center of the capitulum. Any deviation, sometimes there could be mild subluxation, but if you draw this line consistently, you can pick up almost every Montage injury. This is another child who presented to another surgeon who had diagnosed this fracture. Again, heel ulnar fracture. I don't know what the writing means. It's almost like Greek or Latin. Follow-up in clinic, this could mean anything. But what has happened to the child? Again, completely missed Monteneggia fracture. So people look at the ulnar, and I tell you, all residents, again, I will always emphasize, any fracture of the ulnar is a Monteneggia fracture unless proven otherwise. Once you stick to the dictum, you'll never miss these. Okay. So classically, you get children presenting like this. This is the same child, green stick fracture. You can see the slight subluxation. As the fracture heals with more bowing, the head will come out. So it's very easy to miss at this stage. Again, you see how the X-ray quality is. There's an incomplete X-ray, no joint is seen below. And then when the child comes back for follow-up to us, this is the picture. So this is not uncommon in practice, and we've got now a huge series of missed Monteneggia fractures. So what are the main challenges in these? One is the diagnosis and difficulty. I don't think this is difficult. It is just share our kind of negligence, I think. The head can be unstable with any ulnar injury. So if the ulnar injury is length unstable, especially if there's shortening or angulation, the head can come out. The main challenges are for reconstruction. Okay. When do we do the surgeries for missed Monteneggia? When they come with a radial bump, which is a progressive elbow subluxation causing valgus deformity. Usually they get pain with overhead activities or while throwing activities, and parents complain of a bump in the front or the side of the elbow. Several treatment of exams. The most important is to do an ulnar osteotomy. So if you get a case of delayed Monteneggia fracture, you must comment on the ulnar osteotomy. There are various types of osteotomies. You can do a proximal ulnar osteotomy, but always do an internal fixation. In the past, one would do Dr. SD method, never did a fixation, but nowadays one always do plating. You may or may not require to do a ligament reconstruction depending on the duration of the Monteneggia. Never use a pin, a transcapular pin, because of very high chance of stiffness, and never use a transverse proximal radial pin. So from the exam point of view, your approach will be the Boyd's approach: expose the radial head, excise the fibrous tissue which is present inside the joint. Once you excise the fibrous tissue, the head is then reduced, and there's no soft tissue hindrance. Then do the ulnar osteotomy, reduce the head. So once you do the osteotomy, then you reduce the head, and you can see there's no block to it. And then you can plan the osteotomy, and I'll just show you the planning also. So how the treatment has evolved: open reduction of radial head and ulnar osteotomy without fixation was the initial treatment by Dr. Mehta. Later on, we added ligament reconstruction to the osteotomy, and then we added open reduction, ulnar osteotomy with fixation, and ligament reconstruction. So all three can be done. And recently, there have been some experience with external fixators with or without opening the radial head. Now, I've never done this, but some people in the exam, there are papers which have done successful radial head reduction using a gradual distraction method. So you can comment if you read the papers. There's one from Switzerland by Hasler, but I have not done this, so don't comment unless you've seen it. So this is a 9-year-old child with the type 3 Monteneggia. You can see the head is dislocated laterally. Close reduction had failed because of the plastic deformation. So we did an ulnar rodding, and you can see the ulnar is aligned. Once you get the ulnar aligned, head just pops back in. So in the acute stages, this child presented within 3 months, and we didn't have to open the radiocapsular joint. Head, as you did the ulnar osteotomy, the head went back in. So this kind of reduction can be typically achieved in the first 3 months. After 3 months, you get a lot of soft tissue entrapment, and sometimes this may not be successful. In those cases, I always open the radiocapsular joint, clear of all the soft tissues. And if the child presents late, just like this girl, 16 months post-injury, I would do a lateral slip of the triceps, and you can see this is a lateral slip of the triceps harvested from the triceps fascia, and then it is wound around the radial neck and it is sutured to itself. So this radial ligament reconstruction keeps the head in place. The 4 weeks post-op in the cast, and this is the 9-month post-op extent. You can see mild translation, and this is the pressure of the ligament. But child had no symptoms at 14 months. You can see the head is overgrown, well maintained. So overgrowth is not uncommon after these kind of operations, but there's no functional limitation. Another child, 6-year-old boy, we did only an ulnar osteotomy in the proximal part. Open the radiocapsular joint. There is this fibrosis with calcification. The year we could get away with only a KY. You can see it's an open osteotomy, flexion type, and distraction. And here at healing. So ligament reconstruction always not required. If you can get a good angulation distraction osteotomy and with plate fixation, invariably you don't need ligament reconstruction, especially if they present within the first 1 year. You can get away by just doing a good osteotomy. For example, in this girl, when the gap is more than 7 millimeters, use a graft. So you must distract at least 5 to 7 millimeters, use a graft, then the head will stay inside. This is a 3-month post, the same girl, 3-month post-op. You can see the full range of movement, the head has gone back in. The osteotomy is very well healed, and you can see the bump has disappeared. And she's got good range of movement. There's mild overgrowth of the head, which is not uncommon. We also have done this in congenital cases. This girl had a bilateral dislocation, which we did surgery, got the head back in. Again, we did ligament reconstruction here. This is the approach, the Boyd's approach. For the exam, you must know this approach between the ulnar and the anconeus. Also do the Cochlear's approach. And this gives you excellent exposure of the proximal radiocapsular joint as well as the ulnar shaft. And you can extend this proximally to harvest the triceps. This is how I do the osteotomy. I put 2 pins, mark the level of osteotomy, distract it, the lamina spreader, put the plate in, and then pass the screws. The head is located, and you know how much is the wedge to be removed. Typically, the displacement, you can see the amount of displacement is that much is the displacement you require here to get the angulation. So maybe about 15 degrees of angulation is typically required, 15, 20 degrees. And you can see in top X-ray, you can see the head back in. These are the K wires, and then you fix it. If this gap is more than 7 millimeters, I would graft it, or generally they heal up, like in this child. So we never did any grafting here. Slowly he's healed up and he's got full range of movement. So in conclusion, the correct treatment of dislocated radial head remains controversy. So I would say if child presents with symptoms, you must operate, but I would not leave a head dislocated. If they come within 18 months to 2 years, I would operate to prevent a valgus instability. Ligament reconstruction not always required, but if you do correct osteotomy, especially if the child comes within 1 year, you may not need a ligament reconstruction. But also remember the ligament reconstruction will not stabilize if the head is not properly reduced. So if you don't reduce the head, don't depend on this ligament reconstruction. You must make sure the head is reduced. There is no fibrous tissue between the head and the capitulum, and then only you do a plating. Thank you very much. I think that's the last slide.
Atul.
Yes.
So from the purpose of the exam, what is the exact sort of picture they will have? Like an hyperextended elbow and a restriction of flexion and some valgus. And
exam typically, exam, most of the exam cases will have either a full range of movement or terminal restriction of flexion. They have full extension. Extension is not a problem in a Miss Monteneggia. Unless they've been treated, they underwent a surgery and they got some complication and a stiffness, like the child I showed you. Typically, they'll present with a painful elbow or a lump in front of the elbow. And that's how the patient will complain.
So in such a case, the students would want to say that I may suspect an unreduced Monteneggia fracture, but I would like to confirm by taking X-rays, AP and lateral. Correct.
The one mistake I've seen in the exam is where the student says that this is a congenital radial head dislocation or a radial head dislocation. I think one should never say that. You can say that the radial head is palpable, it is dislocated, but I would like to confirm with an X-ray whether this is a Monteneggia fracture. Radial head dislocation is a rare injury. Congenital ones are usually bilateral and posterior, but it's not unusual to get. So one can get a radial head dislocation in a child of 5 to 7 years of age without an ulnar fracture, but invariably it will be a plastic deformation. It can be
congenital radial head dislocation may also have restriction of pronosupination, right?
Correct. Correct. They may have some FFD, some restricted motion, and usually they're bilateral and they are posterior. Very rarely you get bilateral anterior dislocations. So, like I showed you, she was very, very rare bilateral anterior dislocation.
This is a question on the chat box. 5 to 6 years post-traumatic cubitus valgus deformity secondary to Monteneggia, can it be managed by closed wedge osteotomy and any role of radial head excision?
So certainly I would not do radial head excision. Now valgus deformity is not at the elbow. I think one has to be very clear. It is coming from the radiocapsular joint. And one would not do an osteotomy at the elbow, above the elbow. And valgus.
Exactly.
So I would not do that kind of procedure. Don't do a deformity correction at a different level than the pathology. So I think that's the wrong answer. Also, we would never access the radial head. If the child has got no symptoms, you can leave the head alone. If they come, I've got a patient who came to me at 23. He had a mid Monteneggia fracture. He was working as a waiter. Never gave him any treatment. He had some instability, some valgus. He would say, I'm having pain when I lift a heavy object because my elbow doesn't feel very strong. But he didn't have any other functional limitation. So I don't think radial head excision is the answer, and certainly not to correct any deformity other than the site of pathology.
Another thing I have always been wondering is, when do you stop treating a missed Monteneggia? Means now it's 6 years post missed Monteneggia, or 8 years, or 5 years, or 4 years.
Yeah, so I've got a child, up to 24 months I've treated. They will end up with some stiffness. You won't get a full range. But beyond that, I think you have to do the imaging first. If there is dysplasia of the capitulum, the capitulum shape has been lost, and that is seen, and the head is overgrown sometimes, or the head is dysplastic. One should do a CT scan and then take a call, because beyond 20 months, 24 months, there is a lot of misshapen deformity happening in the distal proximal radius, and also what happens is the radius becomes shorter. You may have to sometimes do a radial shortening osteotomy. And I've had one child which was done by somebody else. They put a fixator. The fixator didn't work. So I would not do anything beyond 24 months, to be honest. I think one has to be, and that is from Kim's paper as well from Korea. I've got a larger study and they've actually commented that beyond 24 months, results deteriorate, functional results deteriorate. So one must not attempt doing it beyond 24 months.
Why is there a radial head enlargement is one question in dislocation. Should it not get smaller and dysplastic?
I think it is, usually I've seen the enlargement post-op. Whether we've done a stimulation, it's like getting a coxa magna with the VDRO sometimes.
Or a transient AVN probably.
Or transient AVN. So I don't think it is, if it's not treated, I think it's dysplastic. It may not be overgrown. So what I've shown is actually overgrown. The size of the head increases. So there could be a subtle AVN. We've been aggressive around the proximal radiocapital joint, but it never causes any functional problems. I've never had any functional problem with the overgrowth as long as the joint is reduced.
So I think one of the important point here is that some of the missed Monteneggia may just present as an apparent valgus at the elbow.
Correct.
Right? So I think guys, students who are listening to us, be very careful when you see a case of cubitus valgus. Also keep it as an unreduced Monteneggia as one of your differential diagnosis. And at that time, like what Dr. Atul said, the deformity is not at the elbow and the deformity is actually due to the radial head dislocation. So quickly, I'll now share my presentation. That's the last presentation for the day. So is it visible to everybody? If I can just, Atul, is it seen?
It is seen.
Yeah, okay, great. So now, why have we added this elbow dislocation? So first of all, it's an important case for us. Why? Because we live in a sort of a poor nation, right? So here patients are still being treated by bone setters. So most of the papers on elbow dislocations are coming from nations like ours, Indonesia, which is again densely populated, and the African subcontinent. It's not really coming from the developed world at all. So as long as you're giving your exam in a developing nation, a case of missed elbow dislocation is a fair possibility. Now, second point here is that most of the time we see elbow dislocations clinically in adults in our residency. But one must understand that though rare, but it happens. An elbow dislocation is a distinct possibility in children, as we will see. And thirdly, there is a definite surgical management to all patients of neglected elbow dislocation. And there are very clear-cut papers that every patient of a neglected elbow dislocation, when operated, is always better than if not operated. So there is a definite treatment. So we go ahead. How will the patient look clinically? So the patient is either going to be an adult patient or a pediatric patient. A patient is going to give you a sort of a history in the exam. Also, it may be possible that he's probably under 4 weeks of dislocation or beyond 4 weeks of dislocation, as we shall see how it's very important. And there will be associated injuries along with the neglected elbow dislocation to the elbow or distal neurovascular injuries. And from the front, the patient would look like this with a fairly straight elbow. And when you ask him to flex from about 10 to 20 degrees, he'll be able to come up to about 30-40 degrees of elbow flexion. We'll see what other features are very important. So also they'll definitely give history of being to a bone setter. They'll say that they have a stiff elbow, they've lost range of movement. They may or may not have pain, they may not have neuro deficit, they will definitely have loss of function. And these are the features. So there will be a prominent olecranon and triceps insertion. I think this is the single most important feature, that you are going to have the prominent triceps when you attempt to flex. There will be a semi-flexed elbow, right? The 3-point bony relationship will be distorted as the olecranon has shifted out. Loss of movement, stiff elbow, and there will be ectopic new bone formation. So this article on elbow dislocation clearly says that most of the elbow dislocation happens in developing countries due to bone setters who immobilize the elbow in extension, due to which there is retraction of the triceps muscle and collateral ligament. And we need to consider the surgical approach with or without the triceps lengthening, with or without repair of the collateral ligaments. So we'll just briefly run through a presentation on elbow dislocations in children, which are taken in an IFIX meeting. So imagine you're sitting in a meeting like this and you get a call from your hospital saying that an 11-year-old boy has got admitted with a swollen elbow which is extremely painful. However, he's moving fingers and he's got a pink hand. So the first thing that comes to you in your mind will be, obviously he's got a supracondylar, bad supracondylar has come, or a lateral condyle, because that's what comes mostly. However, you see an X-ray like this. So now you feel, this is definitely not a lateral condyle. This is definitely not a supracondylar. So what is it? Right. So you see this now. Okay. So it was an elbow dislocation. We got it reduced, but the radial neck fracture remains. So elbow fracture with radial neck fractures or associated elbow dislocations with radial neck fractures or associated injuries is a very distinct possibility. It's not so common, but it's not that it does not exist. So summarizing this is elbow dislocation exists in children. They become common after 8 years of age. So this is a very important point. Okay, it's rarely seen before 8 years of age, and they peak between 13 to 14. Okay, and they will never occur before the age of 2 years. Age is very important. So if you get a younger child, be very wary before you say it's a neglected elbow dislocation. It's almost always posterolateral. What you may see is just other injuries of the elbow, and the elbow dislocation may have reduced spontaneously. So you got to suspect that these would coexist, Like you may see just a coronoid fracture of the elbow, but a large swollen elbow. So you will know that probably the swelling of the elbow is so disproportionate to just having a coronoid fracture. So this patient had an elbow dislocation, which is now reduced, and I am now only seeing the coronoid fracture. And it's always posterolateral because obviously the lateral side of the elbow, as you see, is a little more fragile and less stable as compared to the medial side. The medial side is extremely stable, and so posteromedial injury is very rare. And there are a lot of associated injuries, right? In the order of frequency, the medial epicondyle injury seems to be most common, followed by the radial head or neck injury. Okay, followed by the coronoid, and then combined injuries. So these are the kind of patients which we just saw. And now what happened there is that you had an elbow dislocation with a radial neck fracture. Now, how does a radial neck fracture happens? So either while the elbow is getting dislocated, it can take away the radial head and you can have a radial neck fracture. Or while you're reducing the elbow, you can have a radial neck fracture. So this is very important point to understand. This is an X-ray from way back, and that time I'd use a Jess fixator to stabilize. I had actually required open reduction of the radial head. Probably in today's time, I would have used a tense nail retrograde from below up to fix this radial head fragment. This patient was stiff post-op, but definitely better than excising the radial head or losing the radial head. This is a very important illustration to make out in the AP view. So if you lose the congruity between the capitulum and the radial head and the trochlea and the olecranon or the proximal ulna, then it's a clear-cut case of elbow dislocation. You can lose the long axis of the humerus to the long axis of the forearm even without an elbow dislocation in a transfascial separation. So this is normal, this is transfascial separation, this is elbow dislocation, and you can lose these two continuity can be maintained, the medial continuity. However, you can lose the lateral continuity in a displaced lateral condyle injury, right? So when do you, most of the elbow dislocations you will conserve, but when do you operate? So you operate when there are incarcerated fragments, there is persistent instability, which means there is some soft tissue or bony interposition. When you feel there is incomplete reduction, because then you will never get full range of movement, and later on it will become very difficult to treat. When there are entrapped nerves, that means your endpoint of reduction is very soft and the patient actually becomes more painful later after the reduction. And when there are significant associated fractures. And there are a lot of complications, mostly being stiffness, heterotropic bone formation, recurrent dislocations, okay, and vascular and neurological complications of treating elbow dislocation. So this was a patient. Last patient I showed you was with radial neck fracture. So this is an elbow dislocation with the incarcerated medial epicondylar injury. We reduced, and then we saw that moment we reduced, we did an arthrogram to see everything else was okay. The medial epicondyle was still displaced. Okay, so this elbow may remain unstable. So in this case, we fixed the medial epicondyle with a cancellous screw. Now, this is another case of an 8-year-old boy with a 3-month history of an unreduced elbow dislocation. And he had a pain-free range of about 10 to 40 degrees. So here there was a lot of neocalcification, and this is the kind of extensive surgery that you require. You see the radial head exposed here and the triceps VY plasty being done to get the elbow joint reduced. So from the last article, this is one of the most landmark article on neglected elbow dislocation. And what does it say? That you require triceps lengthening if the dislocation is after 4 weeks. Before 4 weeks, you may get away without triceps lengthening. Collateral ligament reconstruction is almost always negative, never required. Concentric reduction is very, very important for you to assure a good outcome. Thorough fibroosseous tissue clearance is very important. You may have to temporarily stabilize the injury if it's very unstable with 1 or 2 K-wires. There are some articles talking about external fixation after reduction, and you will always have an improved range, right? The important point which they mention in the article is, let us say your patient in pre-operatively presented with an FFD of 10 degrees and had a range of only 20 degrees. However, post-operatively, you will have an increased range of movement, but with a higher FFD. So there is a possibility that the patient started like this and came only up to this. Now the patient will land up with this, but he will have better range, a better functional range of movement. So it's always fruitful to operate on neglected elbow dislocation. And if the ulnar nerve is getting tented, then and only then you do the anterior transposition. So let's get a perspective. The presence of concomitant fractures along gives poor results. And one should note that most activities of daily living can be performed with a 100 degrees flexion arc and a 100 degrees arc of pronosupination. So this is what is called as a useful elbow. So what is our aim of treating any stiff elbow in today's session is, you should say in the exam, I would like to give a 100 degrees functional arc, 100 degrees arc in the flexion extension range and a 100 degrees arc in the pronosupination range. So this was the post-op of that particular patient whom we just saw. So you should expect that patients can get elbow dislocation with concomitant fractures, assess and treat adequately. If you fail, then it will become like a neglected elbow dislocation, which we have seen can happen to both adults and children. They are mostly posterolateral. Ask for a distinct history of having visited the bone setter. If the elbow dislocation is more than 4 weeks old, then you will require to do VY of the triceps. If it's less than 4 weeks, less than 4 weeks old, you may get away without a VY plasty of the triceps. And a posterior approach is the only approach which is described for operating upon neglected elbow dislocation. And we are aiming to get a better arc of motion. Thanks.
So, ask you, suppose you get a child who's got a transfascial injury and he presents late. He presents, say, after, now it's an unusual child has had a transfascial injury as a neonate. He comes by age 5 or 4 sometimes. How do you differentiate that from an elbow dislocation? Are there any pointers between a transfascial and an elbow dislocation?
Yeah, I think, so that's where I was illustrating in that diagram is that you will lose. First of all, a transfascial separation in the neonatal age group will generally present as a cubitus varus.
Correct.
In the later.
That's an important point. Yeah.
Yeah. And whereas an elbow dislocation is going to present like what I said with limited range of movement, and a transfascial separation will have otherwise full range of movement in the flexion extension range. And if you look at the X-ray closely, you will find that the long axis of the humerus and the long axis of the forearm may be gone, but the radiocapitular continuity and the humerotrochlear continuity will always be there. But yeah, that's very, very vital, guys. Transfascial separation is a very important and sort of a fairly common thing which we see as pediatric orthopedists, happens in the neonatal age group. And they may get picked up as cubitus varus later on. So I don't see any more questions on the chat box, and we are at 9:55. So I think we've summarized it very well. I'll thank Dr. Atul Bhaskar for taking time out. He had tons of patients and it was tough for him to do so. But guys, please spread the word of this PG clinic to more and more students. You can message to me or Dr. Argekar if you require any improvement. Let me tell you, next time is very hot. We are doing the spine session, so please join in greater numbers as spine is your long case. Next time we are going to be doing examination of spine, disc disease, TB spine, and scoliosis. So we have the star faculty who was there during the course. The same guys are going to repeat. But as you see, we have a longer time to talk to you, so our talks sort of make more contextual relevance, right? Let's try to keep it more interactive. Please try to keep questions posted on chat box. Believe me, we love teaching, but if students are not interested, then our morale comes down, you know. And we have to keep asking professors to take time out, and we have to continue. If we have to cover all topics, it's going to go on till about 2 to 3 months. So boost our morale, spread the word, let people see this on YouTube later. Thanks a lot. Thanks, Atul. Thanks a lot.
Thank you.
Have a
Tushar.
good weekend.
Thanks.
Have a good weekend, guys.
Thanks. Bye.